My dear colleagues, the saga on kinematic alignment continues. Today I will talk about the kinematic technique for total hip replacement. My name is Charles Riviere. I'm a hip and knee surgeon practicing between London and Bordeaux, and I'm part of the MSK lab, which is part of Imperial College London University. So this is the technique that has been initially devised 50, 60 years ago, the mechanical alignment technique for hip replacement. This is a systematic technique. Patients have a specific anatomy. Everyone has a unique hip anatomy, but with this technique, we almost implant everyone in a similar way. The center of rotation of the hip is medialized. The cup orientation is systematically oriented relative to the anterior pelvic plane with a 40 and a 15-degree introversion. The femoral stem anteversion is always between 10-15 degrees anteverted relative to the posterior condylar line. So this has been a very good technique, no doubt about that, but still remain some complication, and not all prosthetic hip feels natural. The residual complications are definitely related because mechanical complication related to prosthetic impingement and edge loading. This has not been changed by higher precision for performing MATHR, and it has been, so the complication has been definitely reduced by a better implant design, notably the more forgiving implants with a larger head, a higher head-neck ratio, but nevertheless, complications still remain. And this is because there are some intrinsical limitations in this systematic AMA technique. First, it does not reproduce the constitutional hip anatomy, nor the physiological soft tissue tension. And it does not consider the dynamic orientation of the acetabulum. It is important to understand that the acetabulum has a dynamic orientation, which is dictated by the lumbopelvic kinematics. And everyone has a unique dynamic orientation, and it is important to understand what is the individual dynamic acetabular intervention if we want to improve outcome of hip replacement. The MA technique is therefore not physiological and not adapted to the spine-hip relationships. Therefore, over the last decades, multiple alternative techniques for implanting total hip replacement, and mainly the cup, have been devised. First, the combined anteversion, where the goal is to obtain around 40 degrees combined anteversion between the acetabulum and the femoral stem. So this is a femoral first technique. Then anatomical alignment technique, where the acetabular component is positioned parallel to the transverse acetabular ligaments. Then has been developed the functional alignment technique, where the cup is adjusted depending on the amount of pelvic tilt in standing position. The newborn, more recent technique is the kinematic alignment technique, where the cup will be aligned parallel to the transverse ligaments, but sometimes the orientation will be adjusted, slightly adjusted, in order to adapt the individual lumbopelvic sagittal kinematics. And this is obviously the topic today. So the kinematic technique, it's not only about the cup, it's about the acetabular, but also the femoral components. So you got a unique constitutional anatomy, and the first pillar of the technique is to restore this anatomy. So you aim to restore the native center of rotation, and as well the native orientation of the acetabulum by using the transverse articular ligaments. Same for the femur, you will try to reproduce the superior, medial, and anterior offset of the proximal femur. The second pillar is that you will consider the individual spine-hip relationships or lumbopelvic kinematics in order to determine if you need to adjust the orientation of the acetabular component. So restoring the anatomy is something that has been promoted for a long time by David Beverland in Belfast, and considering the individual spine-hip relationship is definitely something that has been pushed for more than 20 years by Jean-Yves Latzenec in Paris. So MA and KA technique are different. If you look at the graph in the middle, you see that only the craniocaudal positioning of the femoral stem follows similar guideline between the two techniques. Everything else is different. So it's two different surgical techniques. Why the kinematic technique aim to keep everyone unique? Because you want to preserve patient unicity, so the anatomy. The AMA technique makes everyone the same. And when you look at the limitation that I've highlighted before, it is likely that kinematic technique will solve them because it restores the anatomy, it preserves the physiological soft tissue balance of the hip, and it considers the dynamic acetabular orientation. There are multiple potential benefits. The more physiological implantation will probably improve the prosthetic joint's function and perception. And improving the dynamic interaction between the components will probably reduce the risk of mechanical failure, prosthetic impingement, and edge loading, as I said before. So performing the kinematic hip is not that complex. It's just a little bit different and need to be learned. So I'm going to show you how to do it through a posterior approach. So you do the positioning, make sure the pelvis is well positioned. I usually always do this, making sure that the assists are well aligned in the sagittal plane. You do the posterior approach. When your proximal femur is exposed, you mark the center of the femoral head. You also put a mark on the great trochanter and the lesser trochanter, and you measure. You measure the medial offset. It is the great trochanter at the center of the femoral head, but also the length of the neck between your mark on the lesser trochanter and the center of the femoral head. You do then your cut, and you try to do it perpendicular to the neck, and you control it. When you've done your cut, you check it, and you see that if you follow your cut, you end up in the middle of the femoral head. If your cut is not proper, you need to know how you will need to compensate the positioning of your brooch later on. Then you start with your acetabulum, but you can start with your femur if you want, but I start with the acetabulum. First, I mark the orientation of the transverse ligament. I put my retractor on the transverse ligament, and I put a mark here. This is a dotted yellow line, which is the orientation of my transverse ligaments. Then I rim my acetabulum, and I try to rim evenly. I don't try to go as maximum medially, and I will do as my planification told me to rim the acetabulum in order to recreate the native center of rotation of the hip. Then I impact my cup, and I will so initially align my cup parallel to the transverse ligament. And if I've diagnosed preoperatively poor abnormal spine hip relationship, then I will adjust the cup relative to the transverse ligament. I will explain you this a little bit later. Then I quality check, put my retractor again, and I make sure that my cup end up as I was planning to do it. Then you do the femur, and so you use the orientation of the femoral cut in order to guide the anteversion of your rasp. When you're happy, you measure, making sure that you've restored adequate femoral medial offset and the neck length. Then you do your final implantation, and it's done. So the question, when adjusting the cup orientation, it is very important. You have to do this when you have poor spine hip relationship. In other words, when you have a poor lumbo-pelvic kinematics. So a couple of years ago, we developed a new classification for the spine hip relationship with 6 groups. In a group A, which is a normal spine hip relationship, the patient has a sagittal spinal balance. The patient is balanced, and he's got also flexible lumbar spine. So those patients, they are spine user. Why? Because lumbar spine is flexible, and so when the patient uses sit, switch from standing to sitting and vice versa, there is a shear movement between the hip and the lumbopelvic complex. And for the spine user patient, they don't need, when sitting, for instance, they don't need to use high cone of mobility of the hip, which is probably a protective factor. When you have a native hip, it probably prevents from degeneration, reduce the risk. And when you have a prosthetic hip, it may as well reduce the risk of mechanical failure, prosthetic impingement, and prosthetic edge loading. The 5 other types are abnormal. The spine is stiff. In the type 1 and B, Those patients got a stiff spine, but they are balanced when standing. But when they sit, they do not retrovert sufficiently their pelvis. So those patients in sitting position are at risk of anterior hip impingement and posterior edge loading. In the type 1, the stiffness of the spine is because of spine pathoanatomy. Those patients have a very low pelvic incidence, and those patients with low pelvic incidence have a very low lumbar lordosis, and therefore their spine is constitutionally stiff. In the type B, the anatomy of the spine is normal, but the spine has the poor sagittal kinematics. The pelvis does not sufficiently retrovert or posteriorly tilt when passing from standing to sitting position. Type C and D are patients with spine aging, a degenerated spine. C, it's when it's slight to moderate. D, it's when it's extremely severe. The type C, it's a compensated sagittal spinal imbalance. Why compensated? Because patients stand upright, doesn't need to flex the knee because the pelvis has posteriorly tilted, so they are in hyperextension, but the patient still remain upright when standing with the side horizontal easily. In the type D, the spine degeneration is extremely severe, so the pelvis tilts severely posteriorly and push the hip to anteriorly, and the patient in standing position will bend the knee. He will bend the knee in order to maintain the side horizontal. If the patient extends the knee, then he needs to hyperextend the cervical spine. This is extremely energy consuming, and it affects the patient quality of life significantly. For the fused spine, fused spine is when the spine has been instrumented, and so it makes the spine stiffer, and obviously the level of stiffness is proportional to the level of instrumentation. Regarding the balance, it will depend on the quality of the instrumentation. Some patients after instrumentation have standing spinal balance well restored, while some other it has been insufficient. For the type A, so the normal patient, there is no need to adjust the cup. So the cup will be positioned parallel to the transverse ligament. In this case, anatomical alignment and kinematic alignment are overlapping. All the other cases may need a cup adjustment. In the type 1 and B, those patients have a risk of anterior prosthetic impingement when sitting, so it is important to increase slightly the anteversion of the cup relative to the transverse tabular ligament, and to maintain a cup inclination between 40 and 50 degrees relative to the teardrop line. For the type C and D, those patients are, when standing, risk of posterior prosthetic impingement and anterior superior edge loading. So for those patients, we will reduce slightly cup anteversion relative to the transverse ligament. And also, we will maintain the inclination of the cup between 40 and 50 degrees. For the fused spine type, this will depend how the patient has been fused. In all those abnormal spine relationship types, it is important to use a forgiving implant, high tolerance, regarding the risk of prosthetic impingement and edge loading, and the more forgiving implant being the geomobility. I won't use gravity for everyone, but if you have a patient with a spine relationship type D, elder patient, I would definitely use a geomobility cup. How to define the patient spine relationship? So you need three things: a physical examination and 2 X-ray, standing and sitting, lumbopelvic X-ray, lateral view. If you follow this decision tree that you see on the right side of the screen, you will easily define the individual spine relationship. First, define if the patient, when you see the patient in clinic, define if he has a decompensated sagittal imbalance or not. This is an easy diagnostic to do. If it looks normal, then look at your standing lumbopelvic radiograph. If the patient has a very small pelvic incidence below 30 degrees, is a spine relationship type 1. Then you look at the mismatch between the pelvic incidence angle and the lumbar lordosis angle. If there is a significant mismatch with a lower lumbar lordosis angle, meaning the patient has a flat back syndrome when he's standing, then this is a spine aberration type C. If the patient has nothing of this, then you look at the sitting X-ray. If the delta sacral slope is inferior to 10 degrees between standing and sitting, then it is a spine aberration type B. And if there is more than 10 degrees, and you can tell that delta sacral slope almost equal to the delta lumbar lordosis, and it means your patient is sagittally balanced with a flexible lumbar spine, so is a spine aberration type A. This is, when you use with, is relatively simple, and it takes 30 seconds in order to do it. Overall, in Caucasian population, you got 70 to 80% of patients out of normal spine aberration type A, the other are abnormal. We published last year a case control study where we compare 40 consecutive and selected kinematic hip with 40 matched MA1. Everyone were implanted manually, and it was 1 year outcome. We thought that the kinematic technique better restored all the anatomical parameters. This was expected. And also, we had supine cup orientation as measured on supine X-ray that were significantly higher in the kinematic group compared to the MA1, 22 degrees versus 15. Functional and satisfaction score were higher in the kinematic group, but the difference was not important enough to make it statistically significant. We didn't have any ascaptic complication either group. Our conclusion was that at early term, kinematic hip showed to be safe and with a good efficacy. Obviously, there are some patients with extremely poor anatomy, the one who had a developmental disease, Perthes disease, severe high-grade dysplastic hip, etc. So obviously, those patients, this is another debate. I would not recommend to restore their anatomy, and this is those cases need to be considered case by case. So my take-home messages are that a kinematic technique for hip replacement is an attractive concept like it is for the knee replacement. This is more physiological, this is biomechanically sound, and therefore likely to be clinically beneficial. Obviously, the technique is in its infancy, and a lot of research needs to be done in order to refine the indication on when and at which level we need to adjust the cup relative to the transverse ligaments, and when should we or should we not restore the hip anatomy. In other words, when do we have to do a restricted kinematic alignment technique for the hip. You can read and learn more about the kinematic technique for hip in the AAOS Surgical Insights in the rubric THR Planning. Also in the seminar in arthroplasty, publish an instructional review describing the technique. There will be an open access book soon available with further information. And much more to come on personal arthroplasty. So the book, as I just said, will be in open access very soon, in 1 month or 2. There is a society, the PAS, Personalized Arthroplasty Society, that we have to promote and to educate our community about kinematic technique for implanting prosthetic components. Through this society, there is also a platform to discuss clinical cases, and this YouTube channel of kinematic alignment with more and more video to come. So, dear colleague, thank you for listening. I really hope you enjoyed, and see you in the next video. Bye.